Hey everybody, Dr. Reviso here. In this video, we're going to talk about inflammation, and this is a really big section overall, but what I want to do is I really want to focus on what are the major things that we have to know in this section before we move on. And this section's categorized, differently in different textbooks and that kind of thing, but we're going to cover a lot of the components surrounding inflammation here. So we'll talk about the acute inflammatory response. We'll end with the chronic inflammatory response, which doesn't have quite as much information, but we'll touch a little bit on granulomas. And then in between, we'll talk a little bit about neutrophil migration and then some disorders of leukocyte migration. Okay, so just starting off here with the acute inflammatory response. The big thing is, let's start big picture and then we'll kind of narrow things down. So the big thing is, how does this whole acute inflammatory response take off? And if you've been watching the video series so far, we've kind of already talked about it a little bit. So we said, there might be some pathogen associated molecular pattern. Okay, and this is going to be something that is going to either be released from bacteria or from a virus. And some examples of this include things like LPS, right? Lipopolysaccharide. We see this a lot with gram-negative bacteria. Okay, and then we can also see this with lipoteichoic acid, very classic with gram-positive bacteria. Okay, so these are a couple examples, and then also just in general, we talked about bacteria flagellin also being a pathogen-associated molecular pattern. And again, these are non-specific things, right? Cells recognize these and they know something's wrong. It's not specific to that bacteria though, it's just the body recognizing that there's something there that shouldn't be there, and now guess what? We got to do something about it, right? And so how do we recognize this? We recognize it with recognition receptors, okay? And we talked about this a little bit in the last video. So these receptors will recognize the pathogen-associated molecular pattern. And so an example of this we can see here, you have your toll-like receptor on the surface, right? There's different types of toll-like receptors. Here we can see toll-like receptor 4, which is one of the classic toll receptors that sometimes gets asked about. And then we can see back here our lipopolysaccharide, right? So we have this bacterial component that's binding to the toll-like receptor. Again, very non-specific, but if we follow this process down here, so we go down this arrow here, we can see that eventually this is going to lead to the nuclear translocation of their NFKB. And remember, this is the major transcription factor that you want to be familiar with, right? The bacteria enters the body, and then we use our toll-like receptor to bind to components of that bacterial cell wall in a non-specific way, stimulating innate immunity. That's going to trigger a cascade causing increased stimulation of NFKB, right? That's going to be pro-inflammatory, and that's going to lead to the release of certain cytokines, which we'll talk about in a minute. Interleukin 1, or tumor necrosis factor, TNF, interleukin 6, certain chemokines, and then we'll talk about these endothelial cell adhesion molecules when we talk about how the neutrophils respond to this inflammation and get to one part of the body. Kind of how things are set off. That's the whole cascade of what we're talking about. Now, there's also a couple other things that can happen here. So it's not just the pathogen-associated molecular patterns, okay? That's what we're going to see usually from the invading species. The bacteria or the virus will have these pathogen-associated molecular patterns. But then we also have our own cells that can bind non-specifically. And so what we think about, right? So if I have my cell here, and my cell has a plasma membrane around it, right? If this membrane gets disrupted for whatever reason, maybe a virus hijacked the cell's machinery, right? And now this membrane is disrupted for whatever reason. Well, what will happen is there are certain proteins that can leave this cell once the cell is destroyed. There's certain components here, and these are sometimes known as the damage-associated molecular patterns. Okay, similar to the pathogen-associated molecular patterns, but these are more related to our own cells releasing cell components because that cell was infected by, some invading pathogen. And so again, the damage-associated molecular patterns, or the DAMPs, these can also bind to the recognition receptors. And so this whole process has to do with the pathogen-associated molecular patterns, again, non-specifically binding, the damage-associated molecular patterns from our cells non-specifically binding to the recognition receptor, and then triggering this whole inflammatory cascade. And that's this acute inflammatory response that we get when we have some pathogen in the body. And so how does the body respond to that? Well, there's, this is kind of the classic, very basic, four-corner inflammatory response components to keep in mind. So just important to remember, calor represents heat, right? So when we think of acute inflammatory response, we're thinking about heat, we're thinking about redness, right? The rubor is from redness. And a lot of this is, the heat and the redness, the erythema. That's because we have vasodilation happening. And we'll talk about that in a minute. And then we have pain. Okay, so pain is definitely a component that has to do with bradykinin release. nerve sensitization when we have an acute inflammatory response, right? When you roll your ankle, it doesn't have to be an infection that causes an acute inflammatory response, right? You can have an allergic reaction, you can have trauma to a certain part of your body, and those will also trigger the acute inflammatory response. You might be saying, well, Dr. Viso, how does that work? If there's not a pathogen there, who's going to stimulate these receptors? Well, I just told you, right? The damage-associated molecular patterns. If our cells get damaged, right? If I have some trauma, right, and I break a rib, there's going to be cells that are probably going to lyse, right? And there's going to be some components that are non-specifically going to bind to these recognition receptors, and those are going to be known as the damage-associated molecular patterns that will stimulate this whole cascade, and we'll still get NF-κB to be stimulated, and we'll still get an inflammatory response to that area. And so again, that's going to be the pain, and then we have tumor, which is swelling. So just to recap these, the calor is heat, the rubor is redness, the dolor is pain, the tumor is going to be swelling, and this all can eventually lead to loss of function, particularly if this is chronic inflammation. If this happens over a long time, there's fibrosis, right? And this is very non-specific, but again, just high level, that's what you want to think about. When you're thinking about these toll-like receptors and recognition receptors, recognize, we already talked about this, pathogen-associated molecular patterns and damage-associated molecular patterns. That triggers an inflammatory response. The classic one we talked about is toll-like receptor 4, right? Toll-like receptor 4 and LPS, lipopolysaccharide from gram-negative bacteria. That's the classic poster child for this. The toll-like receptor 4 has a co-receptor known as CD14, and these are expressed, again, in phagocytes of the innate immune system. These are the cells that are going to be kind of looking for these pathogen-associated molecular patterns. And again, this all leads to NF-κB nuclear translocation, as we saw here. And then that translocation is going to stimulate the transcription of a lot of the cytokines that will then trigger the inflammatory response. Okay, now some other things that you just want to kind of keep in mind here, big picture. So the arachidonic acid pathway. Now you can make a whole video just on this alone, but I just want to remind you that there's two kind of segments that we talk about when we talk about arachidonic acid as a precursor. The lipooxygenase pathway, and the big thing, the only thing I really want you to take away from this, we're just going high yield here. We're going to go down our pathway of our leukotrienes. The big leukotriene to remember here is LTB4. LTB4 is going to stimulate neutrophil chemotaxis. Now you know me, I like to think of things in terms of threes. So LTB4 stimulating neutrophil chemotaxis, that's one of the big three that are going to stimulate neutrophil chemotaxis. And if you're not sure what that means, I always think of the end of the term like taxi, right? So you kind of have taxi in the name here. Neutrophils taking the taxi to where they need to go. Okay, so neutrophils are going to get signals, that's where the chemo comes in, chemical signals that taxi the neutrophils to the location where they need to go. So if you have inflammation, neutrophils are kind of like the first responders. If there's a car accident, right, you have your first responders, your EMS, that go out to the scene. Well, that's kind of what your neutrophils are. They're the first ones on the scene. There's chemicals that are going to taxi them to the scene. Okay, and LTB4 is one of those three major taxis to get it there. The other thing on here is the cyclooxygenase pathway, and we're going to talk about this in a lot more detail. There's a lot of specifics here, but the point that you really want to know, just taking away from this big picture, is that prostaglandins are going to get stimulated, they're going to get released. The big repercussion of this really is that you'll see that TXA2, thromboxane A2, is going to also be released, right? You're going to have increased levels of thromboxane A2. And remember, TXA2, if you go to the hem-onc videos, this is going to lead to platelet aggregation. It's going to help platelets get together and aggregate. And this is why when you give a patient an NSAID, for example, so if you give a patient an NSAID like aspirin, for example, okay, so let's just say aspirin here. So aspirin is going to irreversibly inhibit a component of this cyclooxygenase pathway, right? And so by doing that, it's also going to inhibit the formation of TXA2. Okay, so that's what NSAIDs are doing. They're inhibiting cyclooxygenase, right? You might remember, if you think about the pathway of NSAIDs, they are COX inhibitors, right? They're going to inhibit the cyclooxygenase pathway. And this is the same pathway that we're talking about right now. That's why these are anti-inflammatories. What does NSAID stand for? Non-steroidal, right? They're not steroids. It's not a glucocorticoid. They're non-steroidal anti-inflammatory drugs. And they're anti-inflammatory because they're inhibiting the inflammatory process by inhibiting this pathway right here. And they're also sometimes given to decrease platelet formation, right? That's because it'll eventually inhibit the creation of thromboxane A2. Okay, so that's kind of how NSAIDs kind of fit into this. That's how aspirin fits into this acute inflammatory response. We have a whole video just on complement. So I'm going to go through this kind of quick, but we'll talk about this in greater detail. I'm just teeing it up here. So C3A and C4A, probably the least high yield of the ones on here, but it is important to remember that these are responsible for that vasodilation. Remember, I told you, you're going to have some heat. You're going to have some redness. That's because you get vasodilation. Where does that come from? C3A, C4A, right? This complement cascade, and this is all because we have histamine being released from our mast cells. That's what's causing that. Now, probably one of the most high yield ones on here to remember is C3b. This is going to be associated with opsonization. And I know I touched on this before, but remember, you got to tag your bacteria before you digest it. That's what opsonization is doing. So if we have some bacteria here, right? We have some bacteria, and let's say we want to mark this bacteria for destruction. Well, there's two major ways you can do it. You can put complement on top of that bacteria, right? You can put C3b, and that's going to mark this bacteria for destruction. Now, the other thing that you can do that's very effective is you can use IgG. Okay, so IgG, immunoglobulin G, which is typically from the memory response, right? So you're usually going to get this from the memory response because you have to undergo class switching. That's what we talked about in the last video. So this IgG and C3b are very good for marking this bacteria for what? For opsonization. Now, by having these on the surface, you can have other phagocytes nearby, right? You can have a phagocyte nearby here, and this phagocyte now knows to destroy this bacteria or to phagocytose it because it's marked for destruction. And the other thing that can happen is your complement can eventually lead to the membrane attack complex forming on that bacteria. So remember, the membrane attack complex is the kind of the terminal part of complement. So it's C5b to C9. That's going to make the membrane attack complex, and that can also destroy, can basically punch holes into the cell wall of that pathogen. Okay, now I said C3b is one of the most high yield things to remember here in the complement section. The other major thing you want to remember is going to be C5a. Now, C5a is important because it kind of does a couple things, but the big thing it does is it's going to cause neutrophil chemotaxis. And where did we hear about this? We heard about this with LTB4. So LTB4, C5a, remember I said, I promised there's going to be three major chemotactic factors for neutrophils, C5a, LTB4, that's two of them. Okay, so we got two of them. We're going to get the other one as we keep going here. Also, C5a, what else does it do? It also causes vasodilation, very similar to C3a and C4a. So you can just remember C3a, C4a, C5a, they all pretty much do the same thing. The only difference is C5a is the high yield one because it's very good at causing neutrophil chemotaxis. It gets neutrophils to the scene of the crime, okay? Now, bradykinin and Hagman factor, I'll talk about this more coming up, but the big three things you want to remember about this, bradykinin in particular, remember that bradykinin is associated with increasing pain sensitivity. That's very important. Now, it also does other things, increases vasodilation, vascular permeability, but the thing that they love to ask about bradykinin is that it increases the sensitivity to pain. Okay, so remember that. Now, inflammatory cytokines, we have a whole video just on cytokines. Again, a lot of this stuff is interweaving, so we get our reps in, right? So you see this a couple times. But the big inflammatory cytokines you want to remember for the acute inflammatory response, the first one is going to be interleukin 1. Okay, so interleukin 1 is going to have a few different effects. Now, you might have seen this somewhere in this slide, right down here, right? So remember that NFKB, once that's stimulated from that non-specific binding of LPS or some pathogen-associated molecular pattern, that's going to stimulate NFKB to form interleukin 1, interleukin 6, and TNF alpha. And look at that, they're all right here. These are all going to stimulate the acute inflammatory response. Sometimes these are called acute inflammatory reactants. That's another name for them. And I told you that there's one more major factor we want to talk about for neutrophil chemotaxis, so that's interleukin 8. So you have your big three here. You have LTB4, right, coming from the arachidonic acid lipooxygenase pathway. You have C5a from complement, and then you have interleukin 8 from your inflammatory cytokines. Interleukin 8 also does a really good job of continuing inflammation. So if we have some ongoing inflammation, interleukin 8 is really good at stimulating that. Now, the last thing I want to talk about here is some of the additional effects you can get from interleukin 1 and sometimes also from tumor necrosis factor. And the big thing is these can increase the temperature set point. So again, remember, remember this pathway, right? If you remember the pathway here, you can kind of intuitively figure out what's going on, right? We stimulated some non-specific response. This is our innate immune system, had increased NFKB, and now interleukin 1, interleukin 6, TNF are all being transcribed essentially at a much higher rate, and that interleukin 1 and TNF are going to increase your temperature set point. So this is where you get a fever, right? The hypothalamus, the anterior hypothalamus, is going to increase this temperature set point. And then interleukin 1 also can increase the amount of E-selectins and ICAMs on endothelia. And you might be saying, well, what's that? In the next video on neutrophil migration, I'll show you where these selectins are. Essentially, these different molecules are helping either kind of slow down neutrophils as they get to the blood vessel or kind of lock them in one place and have a tight adhesion so that the neutrophils can get to that location. And so you'll see interleukin-1 tumor necrosis factor will help more of those proteins sit on the endothelium so you can get more neutrophils into the area of inflammation faster. Okay, and the last thing on here, damaged endothelial cells. So when a cell is damaged, it's just important to remember this. We talked about this a little bit in cardiology, but you increase your nitric oxide. And the whole reason for that, remember, cGMP is going to cause smooth muscle relaxation, and so you're going to end up with vasodilation. Okay, so you can get vasodilation of the vascular smooth muscle. And then also, the other thing that's going to happen here is when there's cells that are damaged, when there's endothelial cells that are damaged surrounding that area of inflammation, you can increase the number of adhesion proteins. These are your adhesion proteins. Okay, so these can get increased from interleukin-1, from TNF-alpha. They can get increased just because there's damage there. And again, the whole point of that is you can get more neutrophils to kind of slow down as they hit that endothelial wall so they can go into that location. And I'm going to show you some really good images of that in the next video. I just want to kind of introduce it all here, and then we'll go into more detail in the next video. The neutrophils, if you haven't got it already, neutrophils are going to be first responders to get to the site, right? So neutrophils are going to be like your first responders. And so we'll talk about neutrophil migration next. Now, after a couple days have gone by, this is going to be more representative of macrophages kind of coming into the tissue. Okay, so as some time goes by, we end up with macrophages. And so this is kind of the general concept. Like I said, we'll hit on this more in the next video.